Good afternoon, friends. Today we are going to have a small session, but I think it will be of interest to everybody. And we shall be talking something about allergy versus COVID, its manifestations, pathogenesis, and several other things. We will have four speakers with us. I will speak first on the overview of allergy, followed by Dr. Shishir Paul. He will talk on allergic rhinitis, followed by Dr. Chandrasekhar, who will be talking on non-asthmatic wheezing problems with respiratory distress. And finally, Dr. Khilnani will speak on how does acute asthma present and what are we supposed to do with that. So what is pathophysiology of allergic reaction? Antigen binds to IgE antibodies and attaches to receptors on the surface of the mast cells, which leads to activation of mast cells and subsequent degranulation of mast cells. There is release of histamine along with pro-inflammatory agents like platelet activation factor, interleukins, prostaglandins, cytokines, etc., which leads to activation of sensory nerves with increased permeability of capillaries, venules, and lymphatics, leading to plasma leak into the tissues of upper dermis. This can produce symptoms like hives, severage, erythema, angioedema, and other allergic symptoms, including allergic rhinitis, conjunctivitis, and even asthmatic attack. Now, there are basically four types of hypersensitivity reactions. Type 1 response is initiated by antigen-mediated IgE immunes, where they degranulate mast cells and basophils. Type 2 response is cytotoxic, involving complement activation. This is surface the antibody-dependent cell cytotoxicity. For example, we see in hemolytic transfusion reactions, drug-induced hemolytic anemias. Type 3 immune complexes, here the complexes are deposited into various tissues, like in SLE and other autoimmune diseases. Type 4 hypersensitivity is a delayed type of sensitization of helper T cells, where they damage the tissue, for example, graft versus host reactions, tubercular immunity, and contact dermatitis. Then there are certain non-immunological release of histamine. The reactions are similar to type 1 hypersensitivity reactions without IgE allergen interaction. Certain drugs like hydralazine, carbamazepine, phenytoin, sulfonamide, and even vancomycin, they can produce this type of reaction. Exercise, emotional stress, they produce, and certain anaphylactoxins, they are all capable of producing histamine. Is a non-immunological reaction. Now, what are the different manifestations of allergy? Allergy-induced asthma, which will be talked in details by Dr. Khilani. Allergic rhinitis, where there is sneezing, runny, stuffy nose, itching of the nose, eyes or roof of the mouth, and Dr. Shishir Paul will cover it. Atopic dermatitis, there can be itchy, red, dry, flakes or peeling. Food allergy is very important. Like very often we just talk of pain abdomen, some rashes, but there's another type of food allergy which is called oral allergy syndrome, where when somebody who's allergic to certain antigens like uh, tree nuts, they are very important. There will be uh, roughness of the palate, of the oral mucosa, and even tongue. And this type of swelling can cause severe illness also. Sometimes there can be associated body rash also. Drug allergies, we are all familiar. It can be from a fine macular rash to hives to facial swelling and even anaphylaxis and sting allergy. Then how do we grossly differentiate between the common conditions? Like in COVID-19, which is in everybody's mind these days at number 1, there will be fever, cough, tiredness, shortness of breath, and body aches. However, there is runny nose and sneezing is not a common feature, which is a common feature of common cold and allergies. However, in flu, there can be fever with chills, cough, body aches, tiredness, and severe sore throat or vomiting. Severe sore throat is also a feature of COVID-19. Now, rashes can be seen in COVID-19. It can be seen in various types of skin allergies also. About 5 types of rashes have been described with COVID in a Spanish study, where a rash on the hands or feet, it resembles chilblains, which is especially present over the toes. There can be blistery rash, which may resemble the chickenpox rash. They are tiny, similarly shaped blisters. Hives, again found in about 19%. Itchy rash consisted of small, slightly elevated reddish or white patches on the skin. Maculopapular rash was seen in maximum in about 47%. Livido, it is also known as necrosis, was seen in lesser number, about 6%. There is purplish skin with a lace-like pattern, and it was found in older patients with more severe illness, although it can be seen in any age group. Another group has described some dengue-like petechial rash or ovate scaling macules and plaques mimicking pityriasis rosea. This is almost similar. Here you can see there is rash which is more like hives. Hives-like rash, itchy rash, small, slightly elevated, reddish or white patches. This is urticaria type. Maculopapular rash, small reddish bumps on the flat patch of the skin. Blistery rash, like you can see, there are vesicles which are filled with water. The vesicles which are filled with water, they can be seen anywhere, but they are mostly seen on extremities, abdomen, arms, even legs. They are often very itchy, and this is seen more in middle-aged patients. This rash can last for as long as 10 days. This type of rash we might actually get confused with chickenpox. However, we don't get those typical multi-phase lesions as we see in chickenpox. Then libido, as you can see in the picture, this is mostly found in older patients, characterized by purplish skin with a lace-like pattern. This is a sign of poor necrosis. COVID tours are very much talked about, and we all know about that. And these cases are typically affect children and young adults. Acral erythema with vesicles or pustules, so-called pseudo-chilblains, primarily affecting the toes. They can occur in almost two-thirds cases, but in two-thirds cases they appear late. Well, then some people have described Kawasaki-like disease also. Then urticaria, we all know what is urticaria. We classify it as acute, which is less than 6 weeks, or chronic, which is more than 6 weeks, spontaneous, or it can be idiopathic, or it is inducible. These are various triggers: infection, food, medication, contact, idiopathic, then cholinergic, cold, heat, or aquagenic. These are called physical urticarias. Then acute urticaria, the same thing, but almost 50% occur in are idiopathic. We don't know the cause. Then in chronic, we have all types, infections, autoimmune, which is an important thing, and idiopathic also. How do we diagnose? History and physical examination is the most important. Streptococcal antigen in acute urticaria. Then in vasculitis, we should rule out ANA, rheumatoid factor, and other autoimmune disorders. Cryoglobulinemia in cold-induced urticaria. Thyroid functions very important because they can also cause urticaria-like lesions. Serum Ig levels to rule out immune-mediated. Then we have all the causes, and according to the cause, we have to investigate them. Management, we should have a journal principle of management where the goal of the therapy should be that patient is free of symptoms and has good quality of life, needs good counseling for continuation. Since etiology is diverse, The treatment is slow and troublesome, so counseling very important. The best modality is treating the underlying cause if we can identify that. Avoid, eliminate identifiable triggers, rule out all causes in differential diagnosis, and measurement of disease activity and control. Pharmacological first-line treatment is H1 receptor blockers. H2 receptor blockers are only used as adjunct therapy. Second generation H1 are preferred because of the less side effects. We initially give it for 1 to 2 weeks, but can be extended up to 4 weeks. Second line, we still use second generation antihistamines, but we can increase the dose 2 to 4 weeks temporarily. Combining two antihistaminic drugs is not recommended. Increase the dose rather than combining two or shifting between the two antihistamines. Then third line is corticosteroids. We can give it for a short period. Some people have tried methylprednisolone but has no added advantage over plain prednisolone. So they may help in controlling action of other pro-inflammatory agents besides the mast cell. Other drugs, montelukast, along with H1, has got equivocal results, but many children are actually benefited by it. Then monoclonal antibodies, FDA has approved for adults and adolescents in refractory cases, and H2 blockers, they have been given in chronic patients, and the outcomes have shown improvement. However, there's weak level of evidence, and commonly used H2 antihistamine is ranitidine. Thanks. And now I will call Dr. Shishir Paul to talk on allergic rhinitis.
Good afternoon, everybody. I am Dr. Shishir Paul, and I'll be speaking on allergic rhinitis. Slides are not changing. It is the most common respiratory disorder in the world. Around 600 million people suffer from this condition, and prevalence up to 40% has been reported. 80% of asthmatic children have associated allergic rhinitis. 30% of children with allergic rhinitis developed asthma later. In India, the incidence has been reported to be around 15 to 17%. Although a cause of significant widespread morbidity, it is often viewed erroneously as a trivial disease. It is not so benign as we think it to be. Significantly affects the quality of life by way of fatigue, headache, etc. Allergy affecting the nose is called allergic rhinitis or nasal allergy. It is triggered by various allergens like dust, smoke, dander, pollens. These are called allergen triggers. The major symptoms, 4 of them, are sneezing, itching, rhinorrhea, congestion, nasal block, or obstruction. 2 or more symptoms for more than next. Yes. And now nasal symptoms of allergic rhinitis comes in non-nasal symptoms comes in various forms like lacrimation, headache, ear fullness, palatal pruritus, conjunctivitis. Eye itching, fatigue, depression, cognitive impairment, and sleep disturbances. Can I have the next slide, please? Here's one of throat, sniffling, palatoglossal sounds to address itchy palate and hypersensitivity, that is nasal tone of the voice is there. There are various triggers for asthma. Similarly, all allergens have the same type of triggers. Common triggers, as we all know, as various types of molds, etc. General appearance of the face has varied types of things, like the allergic shyness, where the lower eyelid signs. There's an allergic salute, where the child is rubbing the nose from down upwards. That creases in the lower eyelids, which is known as Muller's muscles, Dennis lines. There are allergic lashes, there are long eyelashes, sometimes tear-filled, and uh, Darier's lines. These are the various types of presentation. I'll show you some of the photographs. Like this is the allergic lines that you can see uh, here, here, the creases at the bottom, here, lower eyelid. Okay. Then allergic salute. This is the allergic salute where the child is moving their nose, and this is where there are long eyelashes and you can see tear-filled eyes. This is the allergic gape, constant mouth breathing, and allergic line over the nostrils. Is repeated pushing the nose upstairs. You get a sort of a line there. Then the allergy. You see the process of allergy is in the body is differs. The age of onset, and you can see food allergy and atopic eczema time comes very early in life, and they start fading by almost 2 years of life. Whereas rhinitis has a much later onset, around 4 years or something, and it goes on for a long time in life. And most of the asthmatics in child, they peak around 4 to 6 years and then starts fading in childhood. Now, there are risk factors for allergic rhinitis. There are environmental factors, genetic factors, and genito-environmental factors. Both of them is like small family size, early use of antibiotics, Western lifestyle, dietary factors, passive smokes exposure, atopic dermatitis, high Ig levels, and above at 6 years of age. These are some of the risk factors that can be seen. Allergic rhinitis is not a trivial disease. It often looks and it is called, okay, there's a little nasal block or something, but it is not as trivial as that. Respiratory range of symptoms like cough, sneezing, nasal pruritus and congestion, sore throat, recurrent halitosis, and nasal twang of the voice. Comorbid factors are like congenital conjunctivitis, pharyngitis, sinusitis, eczema, otitis media, obstructive sleep apnea, speech impairment, and failure to thrive and reduced quality of life. Genetics, especially, there is always family history, it is a single most important predisposing a child to the development of allergies. It is the most important factor, a family. There is no specific gender selectivity. High chance of allergic rhinitis, if 50%, if one parent is having atopy, 66% if both of them are there. Now, there are two types of allergens. One are the sneezers and runners, and the other is blockers. In sneezing running variety, you have paroxysmal attacks. Blockers have little or none of that. Rhinorrhea, there is a watery nose, thick mucus plugs are seen in blockers. Itching is very common in the sneezers. In blockers, it is generally not there. Congestion is variable in sneezers, and blockers, they have severe congestion. Diurnal variation is more commonly seen in sneezers. In blockers, it is there day and night. Conjunctivitis is seen in sneezers. In blockers, it is general. There are two types of variants. One is the sneezing variety and the running variety. The other is the blocking variety. The next one. Now, there's a classification. You can have intermittent, or you can have mild, you can have persistent, you can have moderate to severe. These are the four key types. The pattern varies. Next slide. How to control nasal allergy? The best is to avoid allergens, triggers causing allergy symptoms. I mean, triggers, as you know, they're the molds, the dust, the mites, the carpets in the house. Impossible to complete avoid all the triggers, but one can certainly take steps to reduce exposure to them. Allergic rhinitis triggers and how to control them. Avoid exposure to hairy animals. Keep pets out of the bedroom. If there are patches of molds, fungus on any of the walls, get rid of it by cleaning with a mild solution of bleach. Do not smoke and do not allow smoking in your home. Allergy symptoms, signs of allergies, as I told you, like running nose, dry, tickly nose, itching or watery eyes. Nowadays, we are all worried about COVID symptoms in nose. COVID generally doesn't present with much of nasal symptoms. It is more of fever, dry cough, breathing trouble, body aches, very sore throat, fatigue, and gastrointestinal. Running nose or sneezing, etc., is generally not a feature of the COVID disease that we are seeing recently. Now, again, once again, to repeat the difference between COVID-19, flu, and the nasal allergies. In coronavirus disease, the COVID-19, we have fever, cough, sore throat, body ache. Symptoms appear 2 to 14 days of contact. Sneezing and snuffling is not common. In the common influenza that we see, the common flu that we all know, fever, cough, sore throat, and headache is common with fatigue, muscle pain, and a stuffy nose. Allergic rhinitis, you have mainly sneezing, stuffy nose, itchy, watering eyes, wheezing, and breathing difficulties may be there, but there is no fever, etc. The diagnostic test you can confirm by total eosinophilic count, which is more than 20%, and very often total eosinophilic count of absolute is from more than 1,500. Ig levels are high, and confirm evidence for like breath nitric oxide level. It's not a common, but it can be done. Pulmonary function test to rule out other subclinical airway diseases. Specific allergen tests can be done if you want to really rule out a specific allergen. And FADIA is a comprehensive blood test which can be done. And that is basic about allergic rhinitis. Now, thank you so much. Now, Dr. Khilani, Dr. Chandrasekhar will now be speaking on the asthma problems.
Good afternoon. So I'm talking about few words of patient with respiratory distress with wheezing, but which is not asthma. After me, Dr. Praveen Khilani will talk about details about the asthma and asthma management. So what are the diseases which can present with respiratory distress and wheeze? So again, the most important is the history. So depending on the onset of history and the severity, we can find out this what could be the cause other than the asthma. So I think you should remember this word decades said by the Sir William Osler. Listen to the patient, he's telling you the diagnosis. So obviously in our case this is the parents. So it's very important to take the history very carefully from the parents and the observe the patients before we reach the conclusive diagnosis. See, again, most important is what is the presentation? Is it acute presentation, or the presentation or the problem is going for some days or few days or few months? So depending on, we can have some kind of reasonable diagnosis clinically. So I will be worried about this most three important diagnoses if somebody presented with acute respiratory distress, wheezing, and we feel this is not asthma. So first diagnosis, very important, is anaphylaxis. So anaphylaxis may be varied presentation. So one of the presentation of the severe wheezing. So it can present like a acute airway obstruction, skin manifestation, but most important is this wheezing. So because this treatment is totally different. Somebody have asthma, this treatment will be different, and somebody have anaphylaxis, treatment will be different. So in case of anaphylaxis, your treatment modality is we give injection epinephrine 0.1 ml per kilo. So most important, you give intramuscular, not intravenous. You give intramuscular, and your maximum dose is 1 ml without considering the age or weight of the child. So should not give more than 1 milligram. Or if patient is not responding to the first dose, you can repeat the second dose. Again, if the patient is not responding to the second dose, your next important measurement is give IV steroid and start epinephrine infusion if patient has some other associated problem, like if patient in the shock along with the bronchospasm. So next important diagnosis, congestive cardiac failure. The small baby infant, sometimes they can present as a wheezing. So that is very important. If suppose if our first diagnosis is acute bronchiolitis is very common presentation in small baby, we should always look for the congestive cardiac failure. We palpate the liver, auscultate the heart, and if your heart rate is disproportionately very high, you always suspect it could be congestive cardiac failure. And again, your management will be totally different. Here you have to restrict the IV fluid and depending on the perfusion, maybe you have to start inotropic support, or patient maybe need some kind of ventilatory support. And the third important this differential is the foreign body aspiration. I mean to say foreign body in the bronchus. So depending on the position of the foreign body in the airway, the presentation may be varied. Suppose if the foreign body in the main trachea obviously is like a total obstruction, so these need immediate care. Or if the foreign body in the main bronchus, you will have some kind of some time, but obviously patient will present as a acute respiratory distress and the severe wheezing. And next, again, from the history, the importance, the age of presentation. So most of the congenital airway, they usually present either after birth or few months after delivery. Or the problem could be the central airway, like any malacia. Malacia start from the larynx, or malacia start from the trachea, or maybe bronchi, like laryngomalacia, trichomalacia, or bronchomalacia also can present a distress with severe wheezing. Though laryngomalacia or first your important finding will be stridor, but sometimes the laryngomalacia can associate with the bronchomalacia. So in that case, along with stridor, you will have a severe wheezing. The next important cause is extrinsic airway anomalies like vascular ring or sling. So usually they will compress the major airways, and they will lead to the wheezing and respiratory distress. And most common is the right sided subclavian artery or the pulmonary sling. This is the common presentation, common anatomical problem. They will present as acute wheezing. And another is mediastinal mass, which is very uncommon, but the mediastinal mass, like some kind of lymphoma, like T-cell lymphoma, T-cell leukemia, or non-Hodgkin's lymphoma presented at mediastinal mass, they can present like acute respiratory distress wheezing. And obviously lymph nodes, again, non-Hodgkin's lymphoma and sometimes Hodgkin's lymphoma also present as a distress with wheezing. Then other anomalies, the intrinsic area problem, like if patient have a some kind of congenital lung disease, I mean to say parenchymal lung disease like CCAM or congenital lobar emphysema or sequestration, lung sequestration, they can also present as a distress with the wheezing. I think, and from the history, another important thing is what is your context. So context is important. If somebody have a long history of respiratory distress and bronchospasm, so you look for some other what we call the red flag sign. Suppose patient have a clubbing, or the baby is not gaining weight, like failure to thrive. So you always suspect the patient may have some kind of chronic disease, like patient may have a cystic fibrosis, though which is very uncommon in our country, but gradually we are getting case of cystic fibrosis because of the obviously there is a intercaste marriage. People are because the cystic fibrosis is very much common in the European. So most of the sometimes we get a few days back, we get a patient with diagnosed cystic fibrosis. He's made his wife is from the Mongolia. So I think in future we may get more patient like this with cystic fibrosis, which is gradually rising in Indian scenario. Maybe we are getting more cases because people are, or pediatrician more aware of the cystic fibrosis. And another important is the immune deficiency. Suppose the patient, the baby is not gaining weight, or there is a chronic history of respiratory distress and wheezing, and patient is not responding to usual bronchodilator therapy and steroid. So you always think of it could be immune deficiency presenting with distress and wheezing. And obviously most important is the bronchiectasis. So bronchiectasis could be different reason. It could be cystic fibrosis, immune deficiency, or it could be infection related. That can also present as distress with wheezing. And another very important is, I want to mention, say suppose any infant presented with wheezing, our first differential diagnosis is obviously viral infection. So all viral infection, including COVID or some other viruses, they can present distress with wheezing. Or very rarely, so I would say none of the bacterial infection, none of the bacterial pneumonia, they never present with distress with wheezing, except mycoplasma and sometimes very rarely the pertussis. So I think we should remember is somebody with respiratory distress and wheezing, your severe pneumonia, I mean to say bacterial pneumonia, is almost ruled out. You think either it will be viral infection or because of the atypical bacteria like mycoplasma pneumonia or pertussis. Thank you. So
now we are open for questions. Is there any questions? So there is a question that to Dr. Shishir Paul, nasal symptoms is anosmia. Now, please.
Well, anosmia, has been of lately much in discussion because of the problem of COVID. But a lot of authors have described anosmia with any type of nasal allergy and nasal blockage. Although it has been hyped recently with the COVID symptom, that is one of the presenting features, early presenting features. But maybe it happens in COVID. I don't have so much experience with COVID patients till now. But theoretically, it can happen with any severe nasal problem, nasal block, etc. That is my take on it. And I just told you, I have phone calls about some COVID, but till now we were not taking COVID positive patients. We are just starting today, and I can't say what will be the exactly the reports because we haven't been dealing with COVID positive patients. Asthma,
I
Dr.
think it's hardly over for that question. Point to play
Yeah.
excavating.
How many COVID positive babies?
No, sir, last one.
Last
When to plan excavation is
Oh, I
severe.
see. I see. Okay, so the question is when to plan extubation in a patient once you have intubated. Basically, as the PCO2 begins to normalize, as the pH begins to normalize, as the oxygen needs ends up going down and the bilateral wheezing goes down, you should start cutting down your peak pressure as well as tidal volume. So weaning is gradual. There are no set protocols for weaning, but weaning can happen over the next 24 to 48 hours once you start seeing the severity of acute attack going down. And how would you tell that? Sensorium improves, the PCO2 starts coming down, and the bilateral wheezing goes down.
Regarding anosmia, I would like to make a short comment because anosmia, although it has been described in COVID as an early symptom, but patients who have allergic rhinitis, the recurrent or the chronic one, there is blunting of sensation and there is also blockage because of increased size of the turbinates. So there can be partial loss of sensation even in chronic and severe type of allergic rhinitis. However, it has been recorded with COVID as one of the early symptoms, and as doctors have already described that we don't have personal experience about COVID having loss of any sensation of the smell. Any other questions? If not, then we can wind up. So thank you everybody, all the viewers. Thank you so much for your inputs also. Thanks.